Good evening, everyone. So, on behalf of IPS South Zone, I would welcome you all for today's webinar, CME, virtual CME, which is delivered by two different persons, one young psychiatrist and one senior psychiatrist, and which is chaired by an eminent chairperson, Professor Prabha Chandra. So, it is my pleasure to welcome our president of IPS South Zone, Professor Dr. Ramakrishnan, sir, and welcome you, sir. And I welcome the Vice President, Dr. Ramanan Erat, sir, for today's evening of the program. I also welcome the Secretary, General Secretary of IPS South Zone, Dr. Suresh Kumar, and I also welcome my committee members, CME committee members, Dayal, Sai, and all other people who are there. And I would like to extend my welcome to our chairperson today, Professor Prabha Chandra ma'am, who was the past HOD and the Professor of Psychiatry, Department of Psychiatry at DMANS, and she is the president of the International Women's Psychiatric Association Forum, and we don't need a good introduction about Professor Chandra ma'am. We all know that it has been clearly written in many textbooks and many journal articles about her own research activities. I welcome you, ma'am, and also I welcome you. I also welcome Professor Dr. Padmavati madam, who is the director of SCARF, for today's second topic to be delivered on schizophrenia with the physical illness with the different SMI disorders. And also welcome, good evening, ma'am, and welcome Padmavati madam. And also I welcome Dr. Ramya Sampath, who is an young, energetic, vibrant psychiatrist practicing in Chennai, and who is also going to deliver recent advances in the treatment and management of schizophrenia. And above all, I welcome all the participants who are viewing this program of today's IPS Wiser program. And it is an honor for us, the IPS South Zone, to continue the program in midst of our lot of pandemic activities. It has become a eventual platform for all the IPS, and I'm very happy to tell that it's almost about roughly around 350% participants have been registered for today's program, and it is all the support of all the participants and the members, and the topic given by the speakers are very much eminent, and it's very much of day-to-day routine clinical practice. So with this few words, I will just hand over the mic to our president, who is going to give some presidential remarks of today's program. Ramakrishnan, sir.
Good evening to all of you. Thank you, Dr. V.K. Aravind, and welcome all our EC members, Dr. Irath, Dr. Suresh Kumar, and all. It is nice evening. We are gathering, and it has become happened to be an all-women program. Chairman, speaker, two speakers, all are women, all women speakers. So that is also one of the highlights of this program. And the concept of creating Wiser is giving a lot of dividends. Today, 360 delegates are joined. It means three things. People support our program, speakers are good, topic is good, and the chairperson is good. So that is how the platform will build. Even today, Telangana state branch has got a meeting, which they may not be able to attend here. In spite of that, 360 has come, means it is a great evening, a great thing for all of us, and request you all to support like this and promote young generation, because these are the people like Dr. Ramya Sampath are going to hold the stage in the near future, in the next decade. That's my humble prayer to God. That's what I would say. And I need not tell about Dr. Prabha Chandra. She is graceful enough to chair this session. Thank you so much, madam. Thank you. Thank you very much. As Dr. Aravind told, you need no introduction. You are a very popular womanist, I think. So we have got a women group. Do you know, madam? Someone we have started from IPS. Someone we is Women Empowerment Program. So so that is also like this vibrant. Thank you all for joining this program. And knowing about schizophrenia is about knowing ourselves, or knowing about our mind, or knowing about our sky. We don't know. It is a big thing which is endless. But still, Dr. Ramya has chosen a very difficult topic, and I think that speaks volume of the young minds. That is what I would say. And Dr. Padmavati Madam, I cannot tell anything. For the past 25 years, I have been following her. She is community medicine means scarf. Scarf means two people at present. Three people, I would say Mangala, Dr. Padmavati, Dr. Tara. It was founded by Dr. Padma Vibhushan, Sarada Madam. So it is very much right that she is talking about the comorbidities in schizophrenia, which is very difficult. Diagnosing schizophrenia is not very difficult. Giving antipsychotic is not very difficult, but managing the comorbidity is going to be the toughest challenge, and that is going to play a major part in the adherence of treatment. That's what I understand from what she's going to talk. Thank you all. Thank you for giving me this opportunity. Over to Prabhachandra Madam to take over the stage. At this juncture, as a token of our love, I like to present this memento to Prabhachandra Madam. This will reach you tomorrow, Monday, Madam.
Thank you so much.
This is the only thing I could do in the COVID area period. So, thank you very much, and please accept our memento
Thank you
as a
so
token
much.
of love and respect.
Thank you
Thank
so
you,
much.
Madam. Over to Prabhachandra Madam.
Thank you, Dr. Ramakrishnan, Dr. Irat, Dr. Suresh, and all the EC members of the South Zone IPS, and also the CME committee, particularly Dr. Arvind. I think, when we're talking about young, energetic people, he's one of them. And if he calls me for something, I somehow can never say no, because his enthusiasm is so much. So it's with great pleasure that I would like to introduce today's topics as well as today's speakers. So first we have Dr. Ramya Sampath, who is going to talk to us about a very interesting and intriguing topic, the recent understanding of schizophrenia. So from Kreplin's dementia precox to Eugene Bloiler's schizophrenia, to Fuller-Torrey's concept of schizophrenia, to the current concept of network connections, both in terms of understanding the clinical features, the etiology, as well as treatment modalities. I think schizophrenia has always been an elusive kind of a condition. Sometimes people come and ask me what causes schizophrenia, and that is probably one of the most difficult questions to answer. Though, like Dr. Ramakrishnan said, it's so easy, it's relatively easy to diagnose schizophrenia, but very difficult to try and understand it in its completeness, because we know that there is schizophrenias and schizophrenias. No schizophrenia is, even though we have ICD classifications, no schizophrenia is really, no two schizophrenias are alike. It's a great pleasure that I invite Dr. Ramya. Now, Dr. Ramya is a consultant psychiatrist from Chennai. She's a very interesting person because in addition to doing her practice in the hospital, she also does a lot of public education. And she writes for the Tamil website. I have seen quite a bit of material from her on YouTube. And she's an extremely engaging speaker, and I think you will find that she has a lot to tell us. And more importantly, I think a very young person who has decided to put out herself discussing this very interesting and difficult topic. So over to you, Dr. Ramya, before you start. So without much ado.
So, Ramya, just 1 second before everyone starts, I'll ask the moderator from Sun Pharma to put all the persons in mute, please, so that the audio will be clear. Okay.
Sure, sir.
Can all of you see this? Okay. On behalf of IPS and the CME committee, I am happy to present this memento to Dr. Ramya Sampath, our young psychiatrist from Tamil Nadu, Please succeed, madam.
Thank you so much, sir.
Wish you all the best.
Thank you so much, sir.
And you should take the stage in the community case. Thank you, madam.
Thank you so much, sir. A very good evening to one and all. At the outset, I would like to express my heartfelt gratitude to the IPS South Zone, the chairperson, the president, and the other esteemed committee members, CME committee members. My heartfelt gratitude to Arvind sir for having considered me to be a speaker along with Vatmavati madam, which I consider as an honor in itself. So a very good evening to one and all again. So without much delay, thank you for the introductory words, Prabha madam. I think you've given a very great introduction, just summarizing whatever I am supposed to summarize in the end of my presentation. So without much delay, I would like to move on with the topic. So for the next 20-25 minutes maybe, I'm trying to summarize the context and what all that gave me a wow response. So what all I did not know before and what I got to know as I was reading the materials related to schizophrenia in the context of recent advances. I think the slideshow has to be put on, I believe. I can see the other slides also in the side. Yeah, thank you. Next slide. So my agenda would be to just introduce you to the topic. So we'll try to look at schizophrenia, how it was before and how it is conceptualized now. How do we diagnose schizophrenia? Then we'll move on to the recent advances. I've just categorized them like the genetic advances, then the neurobiological advances, then the inflammatory immune-mediated pathways, a bit of the pharmacogenomics, endophenotypes, and things like that. I've tried to incorporate the therapeutic relevance of each of these alongside the discussion so that we get to understand why is it really important to be aware about the recent advances and what the future of schizophrenia can hold for us. So we all know schizophrenia is a very complex and unpredictable mental disorder which affects several domains of cognition and behavior. So as Prabha madam rightly put it, it's a very heterogeneous illness. No two patients with schizophrenia are alike. The saddening part of this group of disorders is, or the spectrum of conditions is, the favorable outcome is only around 20%, even though we are trying to treat them early and we are trying to optimize the doses and trying to psychoeducate them. Still, we haven't achieved a very good favorable outcome response. At least 35% of people suffer from residual symptoms with periodic exacerbations, and 35% have a chronic progressively deteriorating course. They never actually reach their premorbid levels. The current therapeutic domains, mainly the antipsychotic medications, target the symptom domain of schizophrenia. We try to address mainly the positive symptoms when there's a psychotic episode or a schizophrenic episode. So functional recovery, whether the person we treat in our clinic is really going to go back to their work, have they got reintegrated with their family, are they doing their roles in terms of a good family functioning, occupational functioning, social functioning? I believe that is what the health of definition, the definition of health from WHO means. So whether we have reached that state of complete health for people with schizophrenia, most often our answer is no. So there is an unaddressed gap between the functional recovery and just mere symptom remission. When we look at the evolution of the concept of schizophrenia, as Prabha madam rightly put it, from the middle of 19th century, it all first started when psychiatrists started describing young people with this kind of a chronic deteriorating condition with a behavioral issue, and they have a very disabling course. Nobody knew what it was. And after that, as madam said, Kraepelin integrated the concept and called it dementia precox. And then we have Bleuler-Schneiderian concepts. And after that, we got our diagnostic systems in line from DSM and ICD perspective. Currently, in the 21st century, we are currently having the diagnostic systems of DSM-5 and ICD-11, which are the latest in the line. And currently our diagnosis of schizophrenia is only symptom based. So we are trying to deconstruct schizophrenia, and there are a lot of, from the categorical approach, we are trying to move on with a dimensional approach, from a cross-sectional approach to a longitudinal approach while diagnosing a case of schizophrenia. We all know a patient initially believed to have got a bipolar mania or a mood episode. Gradually over years, we understand maybe the primary episode was actually a psychotic episode, which actually is moving in lines of schizophrenia. So we really do not know how the disease is going to evolve over the period of a decade or so. Next slide. DSM-5 is the current diagnostic system. So according to it, the diagnosis of schizophrenia is symptom-based. We are all aware about it. 2 or more of the following symptoms, of the 5 symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. And at least one of these should be among the first 3, 1, 2, 3, delusion, hallucination, and disorganized speech. And the impairment should be very significant, and the continuous that should be a continuous sign of disturbance for at least 6 months, and it is not accounted by any other ways, like by a mood episode or by substance abuse and things like that. So ICD-11, its approach is also along the lines of the DSM-5's idea of how schizophrenia is. Just to mention the recent advance in this diagnostic system, we are totally done away with the subtypes of schizophrenia. We no longer really subtype it as paranoid or undifferentiated or heavy-phrenic and things like that. And it is one schizophrenia with a subtype as a specifier only. And also the undue importance or the importance to the Snyderian first rank symptoms that was there in the earlier classificatory systems is done away with in the current classificatory systems. DSM-5, as I already put it, we have the set of symptoms, but the most bothering symptom for a clinician is the negative symptoms and the cognitive symptoms. So negative symptoms, we all know, just to mention, there can be diminished emotional expression, avolition, poverty of speech, alogia, anhedonia, diminished ability to perceive or experience pleasure in previously pleasurable activities, asociality, so deficits in social functioning. Negative symptoms are more closely related to prognosis than the positive symptoms. So it is not the positive symptoms alone or the duration of untreated psychosis alone that predicts the prognosis. Lot of studies point towards the underlying negative symptoms and the cognitive symptoms, which are believed to precede even the onset of a frank psychotic episode. So they are actually more linked with the prognostic factors than the positive symptoms alone. Cognitive symptoms. I'm able to just see, please move this window away from a shared application. There is some disturbance. Yeah. Cognitive symptoms. So there are deficits in attention, inattention is there, working memory deficits, executive functioning deficits. These cognitive impairments might actually, previous slide. Yeah, thank you. Cognitive impairments usually tend to persist even though the other symptoms are in remission, and cognitive symptoms are significantly linked with the disability of the disease. So a person who you have treated, who's no longer having the delusion and hallucination, may still not be able to go for his office or work or go to a college because the cognitive deficits remain. They can never function at par with the other normal colleagues or the other normal students. So cognitive deficits associated with the illness may not improve over the course of the illness. So this contributes to a significant social and occupational dysfunction, and it is often unaddressed when we are treating a patient with schizophrenia. So coming to the recent advances, we'll start with genetics and move on. So the current research evidence says schizophrenia has a substantial genetic component to it with a high heritability of up to 80%. Genome-wide association studies indicate there are many common genetic alterations, each with a small effect, along with a few uncommon or rare genes which have a larger impact. So if you look at the picture, we are able to understand it's a genetic pool of multiple common genes put together, each with a small effect, meaning these genes by itself do not produce the phenotypic manifestations of the illness, but then it is a gene cluster that is dysfunctional in schizophrenia. And only a very few rare genes have a larger impact. Still, the genes do not account for 100% of the illness manifestation. There are definitely still unknown environmental factors and gene environment dynamic interactions, which explain why some people develop the episode and some people don't, even though they may again have the same genetic vulnerability to the illness. Next slide. So the top candidate genes for schizophrenia, when we look at it as the which has caused the more impact, there is a lot of genes that I came across while reading the material. They have this central functional genomic score based on how much the impact of each of these genes do for contributing to schizophrenia. So the main candidate genes would be, we all know the disrupted in schizophrenia gene and heat shock proteins, myelin basic protein, and things like that. And down the pyramid, we see a lot of other genes, renin gene, neuregulin. So a lot of genes, genetic factors are there. And as I already mentioned, it is not a single monogenic, it is a polygenic condition with a significant environmental interaction. So the current evidence says it's a genetic pool, each with a smaller effect, along with a few genes with a larger effect, which contributes to the illness per se. Next. So this newer area of epigenetics, where epigenetics primarily it is a newer branch of medicine or research which focuses on the modifiable factors or the environmental interactions which have a profound effects on the phenotypic expression of genes. So a person is born with a at-risk gene for schizophrenia or a gene cluster. Is there still something that we can do about their environmental factors or something else in terms of an epigenetic mechanism to lower the risk of schizophrenia? The answer is yes. We have got some research evidences finding some associations between the genes and specific external factors. Some major three things that I came across was the interaction between cannabis use and the AKT1 gene on the risk of psychosis. So really at this point of time, we don't know who's carrying the at-risk gene, who is not. So definitely cannabis use has a contributing effect in its overall spectrum to worsen the risk of psychosis. The second epigenetic research finding is history of fetal hypoxia and the hypoxia related genes on the volume of hippocampus. So hippocampus is the most sensitive area of brain to hypoxia. So any maternal obstetric complication, like we all know during our postgraduate days, repeatedly we take the antenatal history, we ask were there any labor related complications. Now I understand why. So if there is a history of fetal hypoxia, the damage to the hypoxia related genes on the volume of hippocampus is permanent. So improving antenatal care, reducing on the maternal obstetric complications does have a role to play in lessening the impact of schizophrenia in the population. The third epigenetic research finding that I came across was the interaction between childhood trauma or early life events, early life stresses, and specific variants of serotonin transporter and COMP gene on cognitive functioning. So more the early life stresses, there is more cognitive deficits that the person with schizophrenia might have. So with this brief introduction on genetics, we'll move on to the neurobiological aspects. We all know the dopamine theory of schizophrenia, but what is new? What has got added to the newer advances is the glutamatergic hypothesis of schizophrenia, the role of multiple neurotransmitters. It is not dopamine alone that is dysfunctional in schizophrenia. Apart from the neurocircuitry models, there are a lot of immune and inflammation mediated pathways that also contribute to the illness. We shall just discuss each of them in brief shortly. The mesolimbic pathway, the pathway of dopamine, mesolimbic pathway. So from the ventral tegmental area to the limbic structures. We know that's a hyperdopaminergic state in the mesolimbic pathway. And this hyperdopaminergia, we all remember the Stephen and Stahl diagram, contributes to the positive symptoms of delusions and hallucinations. Next, the mesocortical pathway from the ventral tegmental area to the dorsolateral prefrontal cortex, the ventromedial prefrontal cortex. The hypodopaminergic state, less of dopamine in these regions of the brain, contributes to the negative symptoms, affective symptoms, and the cognitive symptoms of schizophrenia. So we would have read it, or we would have, this is what is already known about schizophrenia. So moving beyond dopamine, the next neurotransmitter that has got a very utmost importance in understanding schizophrenia is glutamate. Just a brief on it. Glutamate as a neurotransmitter, it occupies 80% of the synaptic junctions, and the distribution of glutamatergic neurons is mostly projection neurons, the pyramidal neurons in cerebral cortex, and interneurons in the cerebellar granule cells, and granule cells in the hippocampus. So the brain development, as far as brain development is concerned, glutamate has a major role to play in the early stages of brain development. It depresses the excitability, and in the later stages, like close to the adolescent age period, it has a neuroexcitatory activity which promotes neuronal differentiation, migration, has an effect on the synaptic plasticity and pruning. Next slide. So just to mention about the glutamatergic receptors, these things have some therapeutic implications. So I'm just trying to highlight only on those factors which have a therapeutic relevance for us. So the receptor profile of glutamate, basically there are two types. There is an inotropic receptor or a metabotropic receptor. Inotropic receptors are three types based on the agonistic activity of the pharmacologic molecule for which it has the affinity for. It can be inotropic receptors, can be NMDA receptors, can be AMPA receptors, can be kinase receptors. Next slide. So among the receptors, among the whole receptor profile of glutamatergic receptors, the first receptor that is the key implicated in schizophrenia is NMDA receptor. So NMDA receptor, just be with me for a second as I try to explain how the NMDA receptor functions, because it has some therapeutic relevance. So the first, towards your left hand corner, it shows the NMDA receptor in the resting state. In a resting state, the NMDA receptor is blocked by magnesium. Moving on with the second NMDA receptor, when the receptor membrane gets depolarized, even slight depolarization is enough to activate the NMDA receptor per se. So when the membrane gets depolarized, and glutamate and glycine both bind to their respective sites. NMDA receptors is the only essential amino acid receptor which requires the binding of the co-agonist glycine for its functioning level. So NMDA receptor can be activated only when the co-agonist glycine binds to its respective subunit in the NMDA receptor. But when glutamate is bound, glycine is bound, still the receptor is not open as long as the magnesium plug is blocking the channel. So once the magnesium plug is also getting removed when these things bind and the membrane gets depolarized, there is influx of sodium and calcium and efflux of potassium, causing the glutamate current or the active depolarization of the cell per se. So just mentioning it once again, in the resting state, it is blocked by magnesium. The first activation point is binding of glutamate and glycine. Both should bind. It is not either or. Glutamate should be there, glycine should be there at the synapse, and it should bind with the receptor. And the magnesium plug should move out to allow for the influx of sodium and calcium and efflux of potassium for the NMDA receptor to get activated. Next slide. Just if you look at this picture, just specifically look at, there is a glutamate binding site. There is a glycine binding site, as I already mentioned. There is another allosteric binding site. So this allosteric binding site is so promising in view of the therapeutic implication, because a lot of allosteric modulators, positive allosteric modulators, have been investigated in schizophrenia. So what does it mean? What does a positive allosteric modulator mean? It means that whenever there is a PAM, positive allosteric modulator, binds to its respective allosteric binding site, it actually potentiates the glutamic current. But just the binding of that molecule alone is not sufficient to activate the NMDA receptor. But the presence of these molecules in the allosteric binding site, the positive allosteric modulators, it modulates the glutamic current and makes it more functional. So hypoactive NMDA receptor is believed to be the bottom line, or it is believed to play a key role in understanding the pathogenesis of schizophrenia. So normally the excitatory glutamate stimulates the NMDA receptor in the interneurons. There is a resulting GABA release. And this GABA release has a tonic inhibition in the mesolimbic pathway. If you remember the initial picture of mesolimbic pathway, it is always in a state of tonic inhibition and the dopamine levels are always in check. But when this NMDA receptor becomes hypoactive, this tonic inhibition is lost and therefore the hyperdopaminergia happens in the mesolimbic pathway, causing the positive symptoms. Similarly, the NMDA receptor hypofunction on the cortical interneurons increase the tone of the glutamatergic projection neurons. So what happens is there is overstimulation of GABAergic neurons in the ventral tegmental area. There is blunting of mesocortical dopamine pathway. So here a hypodopaminergic state exists, contributing to the negative and cognitive symptoms. So what actually regulates dopamine beyond the mesolimbic and mesocortical pathway is an underlying glutamatergic circuit. Next slide. Just be with me with this picture for a while. So the NMDA receptor hypofunction, what happens is normally this is the bottom shaded part is the mesencephalic dopaminergic cell nuclei. So normally the GABAergic neurons, interneurons keep the dopamine in check, the dopamine output to the striatum in check. So what happens when the NMDA receptor is hypofunctional is there is increased dopamine output to the striatum. There is an excitatory, hypodopaminergic state in the mesolimbic pathway causing the positive symptoms. If you look at your right side of the presentation, the same NMDA receptor hypofunction directly downregulates the dopaminergic activity in the cortical system, causing the cognitive and negative symptoms of schizophrenia. So it is the underlying mechanism is the same. The NMDA receptor hypofunction is believed to play a significant role in this differential levels of dopamine in the mesolimbic tract and the mesocortical tract. Next slide. So just to mention about the AMPA receptor, it shows high density in the cortex, striatum, temporal lobe structures, hippocampus and amygdala. It is responsible for the most rapid excitatory transmission and the fast initial component of EPSP, excitatory postsynaptic potentiation, is by AMPA receptors. And it has a role in learning and memory. So not as though as important as NMDA receptor, but AMPA receptors also have a role to play. Next slide. So those two are inotropic receptors. Metabotropic receptors are basically the G protein coupled receptors, the 7 transmembrane G protein coupled receptors. There are different types. So in that, the consistent type that is expressed in glia is the metabotropic glutamatergic unit 3, which appears to be the only metabotropic subtype expressed in the glial cells, and the 2 subtype is restricted to the cortex and dendrite gyrus. So any dysfunctional expression of these receptors are also believed to play a role in schizophrenia. So in short, summing up the neurotransmitter model of schizophrenia, it is no longer the dopamine alone. So we have a lot of evidence to speak about the role of glutamate next to dopamine. Apart from dopamine and glutamate, serotonin plays a very important role. We all know a lot of schizophrenic patients present with depressive symptoms, even though their psychotic symptoms have got into remission. And in some cases, SSRIs do help in relieving their depressive symptoms, in improving their cognitive deficits to some extent. So serotonin has a role to play, GABA has a role to play. Acetylcholine plays a very important role in improving the cognitive functioning of patients with schizophrenia, and dysfunctional acetylcholinergic receptors also is implicated in a lot of studies as a contributing mechanism for the pathogenesis. Apart from the neurotransmitters and the molecules per se, as I already mentioned, inflammation has a role to play, neuroinflammation. So I'll be speaking about it a little later. Next slide. So drugs modulating glutamatergic signaling. So we all just saw how NMDA receptor functions. Why is it important? So NMDA receptor modulators are N-acetylcysteine, pregnenolone, L-carnosine, which improve the cognitive deficits, which have proven to improve cognitive deficits. And glutamate modulators, D-serine, D-cycloserine, and some other compounds also has a role to play in modulating the glutamatergic signaling. I mentioned glycine as a co-agonist, which is important for a normal functioning NMDA receptor. So similar to like SSRI molecules, glycine transporter inhibitors, which will increase the levels of glycine in the synaptic cleft, those are also studied as molecules. Positive allosteric modulators of AMPA receptors are studied. As I already mentioned, metabotropic glutamate receptors 2 and 3 are implicated in schizophrenia. So positive allosteric modulators at that level are also studied they are also studied in schizophrenia. So the acetylcholinergic side, alpha-7 nicotinic acetylcholine receptor agonists are also studied. See, none of these molecules have got into the approval state. Many of these molecules are in phase 2 and phase 3 trials. So maybe they are in the pipeline, and if they show well in their studies, if they do well in these studies, we can expect them after some time in the future. So the glutamatergic signaling is what is being targeted mainly. Next slide. So with that, I sum up the neurobiological or the neurochemistry model of schizophrenia. Just to briefly mention about the neuroimaging findings, structural findings, we all know there is enlargement of the third and lateral ventricles. There is a reduction in the whole brain gray matter volume. There is reduction. If you look at the picture to your right side, there is reduction in the frontal, temporal and the limbic structures. So the difference is very obvious. This is from a patient with chronic schizophrenia. So it takes a lot of time to show a structural change. Whereas functional neuroimaging we can pick up a lot of findings at an earlier stage also. Next slide. Functional neuroimaging shows reduced activation of the dorsolateral prefrontal cortex during tasks of executive functioning and abnormalities of limbic system activation during tasks involving emotional stimuli. So if you look at the picture above and down, we are able to see there is decreased activation in schizophrenic patients when they perform these actions of executive functioning and when the limbic system activation in emotional stimuli. Next slide. Diffusion tensor imaging is a very, very newer imaging technique which visualizes the connections or the white matter tracks in brain substance. So there is a lot of evidence to show it is not about decreased levels of glutamate or the circuits per se, but there is a lot of disconnectivity between brain regions. So what happens is, apart from the individual dysfunctional circuits, the connection between the right and the left hemisphere is lost, and there is the connection between the individual hemisphere of brain from one region to the other is also lost. So this diffusion tensor imaging findings support the disconnectivity hypothesis of schizophrenia to some extent. Next slide. To integrate this neuroimaging finding, these developmental or environmental triggers also cause an abnormal expression of myelin-related genes. So the myelination is at fault. So myelin is what insulates the axonal membranes, and it is important for a normal conduction velocity. So when the myelination is at fault, what happens is there is a functionally retarded white matter tract. It is not about the structural retardation alone, it is functionally retarded as well. And that may also mediate the neuronal synchronization, how synchronized a brain functions in schizophrenia. Next slide. So moving on to the newer area further, which speaks about inflammation and oxidative stress in schizophrenia. Schizophrenic patients have elevated levels of cytokines in their system. Exposure to infectious and inflammatory agents in utero can cause behavioral alterations resembling schizophrenia. There is reduced level of antioxidant superoxide dismutase in schizophrenia. Why are we so bothered about the inflammatory pathway? The therapeutic implication being various anti-inflammatory agents like aspirin, estrogen, and N-acetylcysteine show significant effects in reducing the negative symptoms mainly of schizophrenia. In contrast, COX inhibitors like celecoxib, minocycline, omega-3 fatty acids, the recent meta-analysis actually did not show any significant difference. Next slide. Looking at schizophrenia from an autoimmune spectrum, we all know, we all would have seen cases of a young female suddenly having the first psychotic episode, not responding to an antipsychotic. The neurologist asks for an anti-NMDA profile, and it turns out to be an NMDA receptor encephalitis. We know why, because the NMDA receptor becomes dysfunctional there. It can be an autoantibody against this receptor or voltage-gated potassium channel. The autoimmune condition and schizophrenia, the link is bidirectional. So we are yet to know how exactly they are linked with each other. But definitely all we can say at this point in time is the link is bidirectional. Schizophrenia, people with schizophrenia and people with autoimmune conditions, there is a significant overlap. Next slide. So now we come up with the concept of immune gene dysfunction, where multiple immune receptors are associated with schizophrenia, including major histocompatibility receptors and toll-like receptors. Complement proteins, we all have read it in the immune pathways. Complement proteins play a very important role in brain development, neurogenesis, migration, and synapse development. The complement cascade is a part of an innate immune system. It's very important to recognize the foreign pathogens and the apoptotic cells, it tags them for destruction, and the macrophages, they by the process of phagocytosis remove them. So this explains the process of pruning which happens at adolescence. So any dysfunctional complement pathways, if you look at the last 2 points in my slide, major histocompatibility locus is located on chromosome 6. It has the highest association with schizophrenia, and complement component 4A, which is located in the MHC locus, is highly associated with schizophrenia. So maybe there is a dysfunctional tagging. So we don't know which neurons to retain, which synapses to retain, which synapses to prune. So a very dysfunctional pruning and neuronal migration causes the ultimate effect of the phenotypic expression of schizophrenia. Next slide. So to integrate, if you look at the picture, we have autoimmune disorders like rheumatoid arthritis, autoimmune diseases, SLE, thyroid disorders having an overlap, thyroiditis having an overlap with symptoms similar to schizophrenia. There is a lot of elevated inflammatory markers, prostaglandins, interleukins, etc. So there is increased inflammatory cells and receptors. So the newer area of exploration is the anti-inflammatory treatment alongside antipsychotics, which has a role to modulate the elevated neuroinflammation, which is primarily dysfunctional in patients with schizophrenia. Next slide. So the another interesting concept that I came across was, this was a very recent article published in August 2020, which spoke about linking air pollution levels and neuroinflammation. So what was more surprising was a lot of immune genes, including those expressed by microglia, are the center of this interaction. So microglial cells are dysfunctional in schizophrenia, and immune genes and altered microglia, altered immune gene expression, that's a significant overlap. If you look at the picture, the genes altered by pollution, air pollution, and the genes altered in schizophrenia, there is significant overlap. So traffic pollution, diesel exhaust, there are specific levels. So nanoparticulate matter, chronic exposure, maybe we all can think about the urban lifestyle, which was believed to increase the risk. So this, maybe I was just thinking on those lines. Air pollution is a very recent advance contributing to neuroinflammation in schizophrenia. Next slide. Gut-brain axis. So gut-brain microbiota dysbiosis can alter the maturation and function of microglia in the CNS, again contributing to the neuroinflammation. Innate immunity of the brain, including microglial function, is sensitive to the gut microbiota. So any alteration there can always alter the neuronal functioning and predispose the individual to have an increased inflammatory level. Next slide. So whatever we have seen so far, previous slide. So whatever we have seen so far, everything put together, the integrated model of schizophrenia, please move to the picture. The integrated model of schizophrenia. On your right side, we know there are genetic risk factors, and we know there are obstetric complications. On the left side, if you look at it, maternal immune activation, obstetric complications, antenatal stress, antenatal infections, exposure to environmental toxins, air pollution, heavy metals like lead, early life stressors, as I already mentioned, early traumatic life events, everything has a role to play, and gut-brain axis. So everything sums up to cause a state of uncontrolled neuroinflammation. And if the microglial cells are perfect, then it tries to achieve a homeostasis through the microglial neuronal interactions. But if they are also dysfunctional, as I already mentioned, there is a lot of immune pathways and inflammatory pathway dysfunction. Phagocytosis is not happening properly. The pruning is not happening properly. Neuronal migration is at fault. Finally, we have a condition where there is altered synaptic plasticity, altered synapse formation, altered pruning. So all these things contribute to the neurocircuitry dysfunction and the neurotransmitter abnormalities and the phenotypic manifestations of schizophrenia. So here we look at decreasing the neuroinflammation by targeting the anti-inflammatory drugs. We can try to follow, as I already mentioned, dietary short-chain fatty acids. They are investigated, but the evidence is not so great. Exercise, reducing the environmental triggers have a role to play in reducing the neuroinflammation. Next slide. So the therapeutic implication, like as I already mentioned, the cognitive symptoms and the negative symptoms are believed to begin lot earlier than the positive symptoms of schizophrenia. So as far as the therapeutic implications of the recent advances, I came across transcranial direct current stimulation during adolescence targeting like at-risk individuals, which prevents the development of positive symptoms, and it can alter some neurobiological alterations. I would not say it can be a cure or it is promising by itself, but there are some studies to support the evidence that it modulates some of the neurobiological alterations in schizophrenia when we intervene even before the first episode of schizophrenia, targeting the cognitive and the negative symptoms. Just a mention about the psychosocial interventions. So it is not antipsychotic drug treatments alone. There is a lot of research evidence which targets correcting the cognitive and the social deficits in schizophrenia. So social skills training, cognitive remediation training, vocational rehabilitation, cognitive behavior therapy, providing the insight to the patient, psychoeducating them, supported employment services. So what we can practically do, even a little step towards helping the patient with schizophrenia across our table, even those minute steps towards rehabilitation has a role to play, and research evidence points a lot of promising outcomes when we intervene early. Next slide. So just to mention on endophenotypes, these are measurable objective intermediate markers between the genes and the phenotypic expressions. So it has not reached a stage where we are going to just test the patients, but there are a lot of neurocognitive endophenotypes, impairments in working memory, other memory domains, neurophysiological endophenotype markers, like especially P50, P300 systems, that is the evoked potential. So when the patients with schizophrenia are given a auditory stimuli, after 50 microseconds, there is a evoked potential. Patients with schizophrenia, usually there is a dampening, but this dampening doesn't occur with patients with schizophrenia. So these neurophysiological and neurocognitive markers are measurable intermediates between the genetic expression and the phenotypic expression. Next slide. Next slide, please. So just to mention on the pharmacogenomics, previous slide. The previous slide, pharmacogenomics. So pharmacogenomics are very promising in predicting treatment response and side effects, but I think we are far from reaching there. Serotonergic system polymorphisms, dopamine polymorphisms, there are studies to associate with it with specific drug responses. Side effects can also be predicted to some extent, like antipsychotic induced weight gain is associated with serotonergic 2C receptor polymorphisms, hypothalamic leptin melanocortin gene polymorphisms. So a lot of things are there. Major histocompatibility markers are associated with clozapine induced agranulocytosis. So maybe when we are starting the patient on clozapine, you want to predict the risk of agranulocytosis, we can ask for this test, but I don't think we can practically use any of this in the near future. But the research is very promising in this area. A lot of research is there into the pharmacogenomic side. Next slide. I think we have come to the last part of my presentation. Next slide. To conclude, gene environmental interactions leading to a developmentally mediated alteration in neuroplasticity. There is a cascade of neurotransmitter dysfunction, circuit dysfunction, and impaired connectivity with onset around early adolescence. So we are trying to move from a symptom-based understanding of schizophrenia to a neuroscience-based definition of schizophrenia. So why are we so bothered about this recent advances? It provides scope for a lot of targeting, lot of interventions. So from epigenetics, from pharmacogenomics, to targeting neurocircuitry levels beyond dopamine, to targeting specific psychotherapeutic interventions, we need a very neuroscientific understanding of schizophrenia. So the focus of intervention is no longer relief of psychotic symptoms alone, but to restore functionality and to reintegrate patients with schizophrenia and help them lead a very normal life. Next slide. So these are my references. Next slide. So when I was reading the articles on schizophrenia, I was reminded of the 6 blind men trying to describe elephant in their own perspectives. Each of them write in their own perspectives, but none of them write when seen in isolation. So I'm very sorry that I took a little more time than I'm supposed to take, but thank you so much for your patient listening. And thank you once again for this great opportunity. Thank you.
Thank you so much, Ramya, for that fantastic talk. I think, making such a complex topic simplified by itself is such a challenge. And you mentioned about the six men trying to figure out the elephant. I think one woman was able to figure it out so beautifully and present it. So thank you very much. There are quite a few questions, but we are going to take the questions at the end. I think you took us through a really wonderful journey inside the brain, from where you started from the gene to circuitry to inflammation to imaging findings, the therapeutic implications, and try to sort of combine everything together as much as possible under the circumstances, because we know there are a lot of unknowns, and many times depending on the researchers' priorities and what they want to focus on, they tend to focus on that. So I think the challenge in the next decade will be to tie in many of these things together. So I'm going to invite you to, wait for the questions after Dr. Padmavati speaks. And so thank you very much for that wonderful presentation. Thanks, Ramya.
Thank you.